Welcome back to Across the Rheum, the official podcast of Rheum Connect, where cutting-edge science meets expert clinical insight in the field of rheumatology. I'm your host, Dr. Sergio Schwartzman, and I'm pleased to continue our three-part series titled The IL-23 Paradigm in Psoriatic Arthritis. In part one, we explored the immunologic rationale for interleukin-23 inhibition and set the foundation for why this cytokine has become such a key target in PSA treatment. Today, in part two, we'll take a closer look at the currently available interleukin-23 inhibitors. We will examine each agent's mechanism of action, clinical trial evidence, and the key differentiating features to help contextualize their use in clinical practice. I'm once again joined by Jessica Farrell, PharmD, and Dr. Monica Schwartzman, who brings both expertise and clarity to this evolving treatment landscape. Jessica and Monica, thank you for continuing our discussion. Let's dive in. Jessica, as we think about clinical implications of the science that Monica just reviewed, can you review these agents with us and give us a little bit of a perspective?
Sure. So in terms of the IL-23 family of agents that we have guselkumab, risankizumab, mirikizumab, tildrakizumab, and ustekinumab. So while these drugs are monoclonal antibodies, they have some slight structural differences, but they are all inhibiting IL-23 in one way. So when we look at all five of these agents, there are some difference in terms of their effect and their targets. So ustekinumab is blocking the P40 subunit, as Monica had reviewed, which affects IL-12 and 23 and can have some downstream implications, whereas the other four agents are blocking the P19 subunit, so only affecting the IL-23 pathway, which is selectively blocking the Th17 axis, as Monica had already reviewed.
We now have multiple interleukin-23 inhibitors available. How do you compare and contrast them in general?
Yes, so we have five agents, and the first thing we'll take in consideration is that ustekinumab has been around for a lot longer than the rest. Ustekinumab, as we mentioned, is affecting both 12 and 23, and it has indications in psoriasis, psoriatic arthritis, Crohn's, and UC. It is available as a IV therapy for Crohn's and UC, and also a sub-Q maintenance therapy, and it's only available for sub-Q administration for psoriatic arthritis and psoriasis. What's nice about it is that it does have a long dosing window, so it is in psoriatic arthritis, it's only dosed every 12 weeks. So I'm not going to cover in detail tildrakizumab because it's only approved in psoriasis. And mirikizumab is only approved in Crohn's and UC. But then when we look at guselkumab, we have this therapy. It was approved in 2017. It has indications in psoriasis, psoriatic arthritis, Crohn's, and UC. It's also approved in the pediatric population for psoriatic arthritis. When we look at dosing, it's dosed in psoriatic arthritis and psoriasis as a sub-Q therapy. It's dosed 100 milligrams sub-Q every 8 weeks. And then when we look at dosing for Crohn's and UC, it does have IV therapy for induction or sub-Q for induction. And it also then has sub-Q for maintenance therapy in those conditions. And then when we look at risankizumab, so risankizumab was approved in 2019. It has indications in psoriasis, psoriatic arthritis, Crohn's, and UC. It's available as a sub-Q and IV formulation. So in psoriasis and psoriatic arthritis, it's approved for 150 milligrams sub-Q every 12 weeks. And then in Crohn's and UC, similar, has IV induction and then sub-Q maintenance.
When comparing effectiveness in psoriasis and psoriatic arthritis, there's always a challenge in clinical trial data, and we lack head-to-head studies. However, if we look at the two phenotypes of psoriatic disease, psoriasis and psoriatic arthritis, and look at all of these agents. Can you please first review the PSO data for us and then the PSA data?
Sure. So I think it's important to note that in general, when drugs are being studied for psoriasis and psoriatic arthritis, that they're often going to get an indication in psoriasis first because it's much easier to study. So when we look at the efficacy data, we're looking at PASI 90 scores and responses. So most of these studies that look at efficacy in psoriasis are, primary endpoint is at 16 or 24 weeks. So with ustekinumab, we have a delta or treatment effect of about 50 to almost 60%, which was in both the Phoenix 1 and 2 trials. When we look at tildrakizumab in psoriasis, the treatment effect or the delta was about 57%, and that's based off the data from the Resurface 1 and 2 trials. Guselkumab has a little bit of a higher effect, so we'll see a PASI 90 response. The delta there is 67 to 77%, which was seen in the Voyage 1 and 2 trial. And then risankizumab also has a pretty good delta, so 73 to 78% for that PASI 90 score. And then mirikizumab has a smaller delta with a 63% with that PASI 90 score.
It's certainly interesting to look at the psoriasis data because, as you mentioned, psoriasis trials are so much easier because of the outcome and because there's a lot more people with psoriasis than people with psoriatic arthritis. Let's look at the psoriatic arthritis data in a similar manner.
Okay, so when we switch gears to psoriatic arthritis, the primary endpoints focus on joints. So you'll see ACR20 scores as the primary endpoint in all of these studies. Among other secondary endpoints includes ACR50s, which, in my opinion, is a more meaningful clinical outcome measure to look at.
When we look at ustekinumab in terms of joints, ACR20 scores ranging from 42 to 50%. When we get into the ACR50s for ustekinumab, ranging from 22 to 28%. And those deltas are a little bit smaller. So, ranging from 19 to 27 for our ACR20 scores, and then 13 to 19% for our ACR50 scores. And that was based on data from the P-Summit 1 and 2 trial. Then when we look at guselkumab, we have ACR scores that are a little bit higher, ranging from ACR20 of 59 to 64%. And that delta is 26 to 30% for the ACR20. And then we look at ACR50s, we have 33 to 37% of patients meeting that endpoint with a delta of 19 to 23%. And then risankizumab, we have ACR20s ranging from 55 to 57% and ACR50s ranging from 30 to 35%. So that gives us a delta or treatment effect of an ACR20 of 22 to 24% and ACR50 of 19 to 24%. And that's based on the Keepsake 1 and 2 trial for risankizumab. So I think with psoriatic arthritis, in rheumatology, we know these drugs work really well for skin, and joints are sometimes our trouble spot. So we're trying to find drugs that are both effective for skin and joints. And you can see that based on these responses in the ACR20s and 50s, that guselkumab and risankizumab seem to do a little bit better job at treating our joints. While these aren't head-to-head trials and we can't compare them across these trials, when we look at those ACR 20s and 50s, we want to see those scores up into the 60s if possible for ACR 20. So,
thank you very much for that great clinical and complete but short summary, which is always very helpful. So I think in terms of questions, I'll start off. So in the first episode, Monica referred to the fact that we have as many interleukin-23 agents technically as we have anti-TNF agents. And as such, one of our practices as rheumatologists has been sometimes to cycle through agents, to go from one TNF agent to another agent. Would you go from one interleukin-23 agent to another interleukin-23 agent?
Yeah, so pulling from some of our data with the TNF inhibitors, there are, reports and studies that look at switching between those drugs. And I agree with you. We didn't have, outside of TNF inhibitors, we really had no option but to cycle. Clinically, we, sometimes do see patients have a difference in response between the TNF inhibitors. But when we look at IL-23 inhibitors, there aren't any, large studies looking at switches. But there are some case series studies that look at switching from risankizumab to guselkumab and guselkumab to risankizumab. And that data does show that there is some benefit and that some patients do better. I don't know that we know exactly why. It might be related to the structure, and it might have something to do with, where I would like to see our field go is pharmacogenomics. So is there a role for, pharmacogenomics in response to therapy? I thought we would be there by now, but we're not. But that could explain, the difference in effect when switching.
And another caveat in terms of switching within class is we know that whenever you switch within class, you're less likely to respond. And we learned that from the anti-TNF agents. And I think if you only have a very few drugs in one class available, then it makes sense. Mm-hmm. Whereas we have now 15 drugs approved for psoriatic arthritis. So I think switching within class may be educational, but I think from a practical perspective, we have so many other choices that I would favor switching class.
Exactly. Same.
All right. Any other questions?
So I think kind of picking up on this theme of we have a lot of options available to us, and we have 5 FDA-approved therapies in the IL-23 class, although not all in the same disease state. What do you think about head-to-head studies within this class?
So there are some different head-to-head studies in the psoriatic arthritis space. However, there are not any IL-23 to IL-23 inhibitors against each other. So none of those head-to-heads. But there are some that are published looking at IL-17 inhibitors against TNF inhibitors, also a JAK inhibitor versus a TNF inhibitor. And then just at ACR, just recently, there was a study that looked at secukinumab, an IL-17 inhibitor, against ustekinumab. And then there is another study that is getting started that's looking at an IL-23 inhibitor, risankizumab, against an IL-17 inhibitor, bimekizumab. So I think while they're not within the class, so not IL-23 to IL-23, I think it is really helpful to have those head-to-heads to help us, guide our decision, on a specific patient that whether we choose one of those therapies before another. So, yeah.
Completely agree. And I think the dermatologists are way ahead of us in terms of head-to-head studies. So it's very encouraging that we're starting to hopefully catch up a little bit with some ongoing trials.
But we're not actually at the bottom of the pyramid. The gastroenterologists are below us in terms of head-to-head studies. I'd like to thank you both, Jessica and Monica, very much for your input. That brings us to the close of part 2 of our 3-part series on the IL-23 paradigm in psoriatic arthritis. We hope this discussion provided clarity on the currently available IL-23 inhibitors and the evidence base supporting their use. In our final episode, we'll turn our attention to the clinical positioning and real-world utility of these agents, translating data into decisions that impact on patient care. As always, we invite you to follow or subscribe to Across the Rheum, the official podcast of Rheum Connect, so you won't miss what's next. We'll see you in part 3.